he did mention that it will disturb everybody. I'm sure it would have disturbed at least some people. But I also hope that it will make people reflect on many of the points that he very forcefully brought about. And that is, of course, that will, of course, provide immense hope for social psychiatry, not only in India, but globally, because it's one of our own who will take over as the president of the World Association of Social Psychiatry in less than 3 or 4 months in Marrakesh, when the World Society meets. So, Dr. Basu, thank you very much for that very thought-provoking presidential address. Now, thank you also for choosing this theme, social determinants of mental health. Some of those issues have been coming up right from the morning inauguration. Some of the things that I'm going to talk about was raised by our Dean, guest of honor, who talked about premature mortality because of various reasons. He did mention about some of the social determinants, such as poverty, etc., etc. And then, of course, in the presidential address, we saw a number of issues which link to social determinants of mental health. So thank you for choosing this theme. And also, I am immensely grateful to the organizing committee as well as the official office bearers of the IASP for inviting me to speak on this topic today. Now, much of what I'm going to say is based on an experiential base, not so much of my work here in India, that was in community mental health, rural mental health, district mental health program, etc., etc. But it is more from the last 10, 15 years of work, heading 2 teams in the Fremantle Hospital in Australia, in Western Australia. One is something which all of us know, the early intervention psychosis team, wherein I see young people who are, this is a very specialized team for assertive follow-up in the community. Young people who have developed a first episode of psychosis, many of whom have got admitted for a brief period of time, are referred to us for assertive follow-up to prevent relapse, prevent rehospitalization, prevent recurrence of the illness, etc. We very proudly call our intervention recovery-oriented intervention, etc. So we follow them up for many, many years. Our team has a obligation to follow for minimum 3 years and maybe up to 5 years. Simultaneously, I also have been heading another team called the Assertive Community Treatment Team. Assertive Community Treatment Team is for people who have had long-drawn illnesses, serious mental disorders of, they are like people with 10, 15 years of psychotic illness such as schizophrenia or bipolar affective disorder, who have been in and out of hospitals. So there is an assertive community follow-up with additional staff, etc. So what often disturbs me is I see these young people, 17, 18, 19-year-old with first episode of psychosis. On the same day, I see some other people, who have had 15, 20 years of mental illness, who have reached this state, gone through the revolving door, and now are being followed up. So the thought always is, how have these people reached that stage? What can psychiatry do to these people? Okay. So this is the outline. Only about 15 minutes. I'll quickly try and finish. I'll tell you why I chose the topic of closing the gap of premature mortality in patients whom we see on a day-to-day basis in our own clinic. Often we neglect those patients. That's another theme. I'm not going to talk about that. With advances in mental health, with greater awareness, we now focus on adult ADHD, autism, gender dysphoria, etc., at the cost of or neglecting care for persons with serious mental illness. And that's why I thought of choosing this particular term. I'll briefly mention about closing the gap, the scandal of premature mortality of mentally ill people, social determinants versus commercial determinants. The last several slides of Dr. Basu in his presidential address was talking about the commercial determinants of health. He talked about the pharmaceutical industry. He talked about how it involves training. He talked about how it's interfering with research, etc., etc. I'll briefly touch upon that and end with what can we do. It's all good to talk about what you and I can do as clinicians sitting in a clinic in PGI or NIMANS or anywhere in the country. So this closing the gap theme has come with my work in Australia. Australia, the famous closing the gap is not about reducing the longevity of life of people with serious mental disorders, which is, we all know as PGs and psychiatrists, that it used to be more than 15 years, but now, even after a lot of intervention, it's about 13 to 15 years. That is, the general population and persons with severe mental illness, persons with severe mental illness die 15 years younger than other people. So this closing the gap is not about that. This is an Australian national goal. Closing the gap between the longevity of life of people called the first Australians. This is the Aboriginal community and the other general population of Australia. That is again a scandal. It's about 15 to 20 years. In spite of very, very lavish spending and all that to improve things, as things happen in our country and many other countries in the world, we have not been able to close the gap. Closing the gap was the target given in 2018. In 2020, when they looked at it, the gap has not reduced at all. So now it is on a war footing that in Australia so this is the cover of the latest Closing the Gap report. There are metrics which are looked at every 6 months, etc. So it's on a war footing. But I'm still not very sure how we will succeed, because some of the social determinants which contribute to this will also have to be acted upon. Now about the topic that was about the closing the gap of the Aboriginal mortality longevity gap. Now let us talk about our own patients. This is this is the cover of a research done when I joined the Department of Psychiatry at the University of Western Australia. It's called the Duty to Care Report. It is about physical illness in people with mental illness. It was published in Social Psychiatry. This was a book cover. The major authors were David Lawrence, Darcy Holman, and Asen Jablonski. Asen Jablonski, the late Asen Jablonski professor, was the head of the Department of Psychiatry. At that time, they were talking about this duty to care by all of us because there is a longevity gap. Today, of course, the longevity gap of amongst people with serious mental disorders is known to everybody. But one of the earliest research was this, done in 2000, published in 2000. In Western Australia, you have, like in some Scandinavian countries, this record linkage. If you get access to the record linkage and get permission, you can look at the trajectory taken by a person with schizophrenia. Where was he born? Was there any perinatal problem? How was his childhood? All from the medical. So this is a population-based record linkage study done by David Lawrence, Darcy Holman, and Asen Jablonski in 2002, which showed significant life expectancy gap in persons with mental illness as compared to the general population. And they also said that the gap is because of very simple, preventable physical disorders. Now, same team repeated this work about 13, 14 years later. This is again, no time to go into the details. Paper published in the British Medical Journal in 2013. The gap, with all the things that psychiatrists were doing, governments were doing, mental health commissions were doing, the gap in life expectancy from preventable physical illness in psychiatric problems in Western Australia had not come down. It was remaining the same. I would imagine that if somebody does or repeats this study, either in WA or anywhere in the world, the gap would not be very different. You know, it's coming down, but we are not aggressively dealing with it, so it's not coming down. And that is what, this is again several years ago, Graham Thornycroft, he is Sir Graham now, a very well-known British community and social psychiatrist. He said, it's the scandal of physical health disparities and mental illness. He called it a scandal. So this is a thing that I am talking about. This is the closing the gap that I am talking about. Now, what is important is this gap in longevity of life of the mentally ill is across the entire spectrum of mental illness. It was initially thought that suicide is contributing to it. No, physical illness is one of the major problems. It is not just for people with schizophrenia, it is for people with bipolar affective disorder, it is for people with personality disorders. Across, it is trans-diagnostic. Now, there is data to show depression and the longevity of life of a cohort of people suffering from depression being treated with depressive disorders and the general population. You find that the same gap is there. It is across the spectrum of diagnosis. It is across all income level countries. It is there in low income countries. It is there in middle income countries. It is there in high income countries. In fact, of course, from low income countries, we don't have many robust research papers. Much of the data comes from Scandinavia, high income countries. And we also know that much of this longevity gap is not because of suicide, not because of accidental deaths, but because of poor clinical management of the physical comorbidity. And of course, now younger people here will know, oh, we are giving clozapine, we are giving olanzapine, we are producing the metabolic syndrome. That is contributed to it, but even much before clozapine was discovered or olanzapine has been used, this longevity gap was there. If you look at papers 30 years ago, 40 years ago, it was tuberculosis. What we heard from the dean this morning was tuberculous meningitis. 30-year-old man dying, not because treatment was not started, but we heard what he said. So, due to poor clinical management of physical comorbidity in the mentally ill. Now, where does the social determinants come? I'll give you a little, because many people, it has already been highlighted by our president in his address that social psychiatry is dwindling. People don't look into any social the word social comes, you delete it, you don't even read. The data has already been shown, and that is all over the world. So just for the information of the people, I'll give you a little historical background. I'm sure my other speakers in the symposium will talk about it. The Commission on Social Determinants of Health was established only in 2005, because by that time, health leaders, policymakers realized, like our dean said this morning, medicines are not enough. There are much more important issues which determine whether the patients will have a good health or not. So although the commission was, chaired by Michael Marmot, many of whom you might know, is not a psychiatrist, medicine person, who talked about the differential income levels and mortality levels, etc. He chaired the Commission on Social Determinants of Health. The report came 3 years. They deliberated, did excellent work. Came in 2008. Health equity through action on the social determinant. That was there. Unless you make health easily accessible and available and provide equitable kind of health care to everybody, that was the main theme of the social determinants of health. Highlight social factors contributing to ill health, like poverty. But I chose the term closing the gap because even that report which came out in 2008 said closing the gap in a generation. Their goal was in a generation we should reduce the gap of accessibility to healthcare. The differentials have to be reduced. Now, what are social determinants? Again, we have talked about social determinants of health are the conditions in which people are born, grow, work, live, and age. The systems put in place to deal with illness and the wider set of forces and systems shaping the conditions of daily life. Then, of course, social determinants are important for health, all healthcare. Now, there's a specific document on social determinants of mental health, not only just a document for people who don't want to read the full document. There's an excellent paper which came out a year ago, 2024, The Social Determinants of Mental Health and Disorder, Evidence, Prevention and Recommendation. So, we will be the whole symposium is to throw light on this, but there is a World Psychiatry paper followed by about 8 or 10 commentaries. Please do look up this. We have already been told that social psychiatry is not being searched at all, but I'm making an appeal. Please read this paper, because 4 speakers talking about it will not be able to touch upon the real issues. You must not only read, but reflect on this and act on this. And how you can act, I will now end by talking about it. Social determinants of mental health. What are the social determinants? In simpler layperson's terminology: early life adversity, socioeconomic disadvantages. Early life adversity, we again heard about, food and hunger being weaponized, and some of the papers, I'm inspired by the presidential talk. I cannot help by bringing in some of the things that he talked about, but socioeconomic disadvantages, ethno-racial discrimination and marginalization of population. Although it's a minority, but I'm talking about marginalized populations who are different, who have different sexual orientation, etc., etc. Social isolation and loneliness, inequitable access to resources, including healthcare. These are all social. So this is just to give you an example of, even in Australia, there was this study called the SHIP study, the survey of high impact psychosis. In terms of the actual prevalence rates, psychosis is not very much as compared to depression, anxiety, etc. But in terms of impact, it's very high. So this survey is called, Asen Jablonski was the leader, Vera Morgan is a key author, again led from the department where I work, all Australia study. Please read this paper, which shows that people with chronic severe mental disorders are at a tremendous disadvantage. And one of the major problems is a chronic physical ill health in them. Now the last point, again not going on to details, but which has already been highlighted in the previous talk, the commercial determinants of health. It has now been, we were focusing on social determinants, and now we have realized that we are overtaken by the commercial determinants of health. What are they? The private sector activities and influence that affect people's health and health policy. Again, when Dr. Basu talked, I was remembering a young girl who all her savings, she used, spend it to get some genetic profiling by some Singapore commercial company. I asked her, how much did you have to pay? She said $150, $200. She brought the whole profile. I said, for $200, you would not get this. She didn't want to tell her parents that she had. Then I asked her, why did you do this? No, I want to know whether I'll get this and that. This is how commercialization can interfere with health, useful. Anyway, private sector activities, conditions, actions, and omissions by commercial actors that affect health. Pharmaceutical companies have been mentioned, but there are numerous other companies. The corporatization, the privatization of healthcare, including what is happening in our country. These are all commercial determinants, also drive inequities which contribute to the scandal of, how can we close the gap? I'm concluding now. For every patient whom we see with a chronic severe mental disorders, total multi-professional clinical care, focusing also on the comorbidity, not just treat the schizophrenia or the bipolar with lithium carbonate or clozapine, but the coexisting morbidity is extremely important if you have to respond to this scandal. Identify and manage the lifestyle risk factors, which are plenty in most of our patients. I'll tell you in the next slide. Lifestyle interventions are core. They should become part of our core clinical practice, including social prescribing. That is the latest terminology used for this. So Lancet has come with first it came in 2019 with a special commission, Lancet Psychiatric Commission, on protecting the physical health of people with mental illness. And more recently, they have come out with an update. I'll conclude with that. Now, what are the lifestyle risk factors which affect our patients? high rates of smoking, other substance use, alcohol, cannabis. In the place where I work, a lot of methamphetamine, various other kinds of things. High levels of sedentary behavior, poor sleep hygiene, lower diet quality, detrimental eating behavior. These are all things which are in our hand. Now, can you and I do anything about poverty? That's a different matter. But these are things which we can, by spending 5 more minutes with every patient, we can certainly involve. This is a chart. This is from the blueprint for protecting physical health in mental illness. I will conclude by saying that just 1 week or 2 weeks ago, Lancet Psychiatric Commission came with implementing lifestyle interventions in mental health care. Third report of the Lancet Psychiatry. They talk about specific practical steps which all of us can take. Not ministers, not governments. You don't require additional resources. In your clinic, of course, you require an additional resource, little more time, and little more passion and interest in doing this. And the last, they have come out with, now they are looking at how can you improve the health accessibility, World Report on Social Determinants of Health Equity. A lot of problems are there because it's a very inequitable kind of health delivery. So my message is, see your patients with severe mental disorders. What kind of lifestyle changes can you, as a change agent, produce in them to reduce their physical health problems? A lot of them have diabetes, hypertension. I don't have to go into the details of that. Thank you very much for a patient listening.
Thank you very much, sir. As usual, a pleasure to listen to you. And thank you also for sticking to the time limit. And number 2, for setting the stage for the rest of the symposium. And with this, I would like to introduce our next speaker, who's an eminent person in himself, Professor Roy Abraham Kalivel. He also needs no introduction. Sir is the past president of IASP and also the past president of WASP, that is the World Association for Social Psychiatry. And he holds multiple positions and has had multiple awards and honors. And obviously he's got a lot of interest in social and community psychiatry and also in ethics. And he'll also be speaking on later in the conference on a special symposium from the WPA on ethics. With these few words, I'll invite Professor Roy Abraham. We'll take all the questions in the end after all the 4 speakers have given their talks. So with this, I'll invite Sir to start his presentation, please.
First of all, dear chairperson, Sir Basu Gupta and Professor Mohan Issac. It's a great privilege for me to be back here about 40 years after leaving PGI, left in 84 December. But I remember one thing, the last thing which Professor Verma at that time, the day I left, when I went to say, sir, I'm leaving, he gave me an application form of IASP. And he said, you are going to be the first member of IASP from Kerala. You are going to, your task is to build up social psychiatry in that part of the country. So I think I have lived up to the mandate he has given to me. I also especially remember my teachers, Dr. Kulada, is he here? Or Dr. Sabita, and all the people at that time for giving such a wonderful time. Dr. Basu, I want especially not only for your presidential address, but the challenges you take up in social psychiatry. For example, when we had the World Social Psychiatry Journal, we wanted an editor who were going to do the job. And then Basu came forward. We talked to him, he agreed, and Nitin gave him wonderful support. And thank you very much for all you have done for social psychiatry movement. It's a movement all across the world. And it's very difficult to speak after 2 such eminent speakers. Dr. Mohan Issac, he is the person we make the safest investment. When you want a speaker who will not disappoint, is always Dr. Mohan Issac. So now I will just, in about 20 minutes, I think I will be able to cover this topic. Why do we need to study social determinants in this biomedical dominated era? Many of these things, some of this, there will be overlapping with Dr. Basu has said and Dr. Mohan Issac has said. Man is the only animal for whom his own existence is a problem, which he has to solve. So we have to solve our problem. Social determinants of health are the non-medical conditions in the environment where people are born, grow, live, work, and age that influence health and well-being outcomes. These factors, including income, education, housing, and access to nutritious food and safe environments, play a more significant role in health than genetics or healthcare access alone. Addressing social determinants of health is crucial for improving population health and reducing health inequities by promoting equitable policies and access to resources. All of us know this, but this is a very basic knowledge we should have. In today's biological dominated era, understanding mental health requires looking beyond neurobiology and genetics to the social determinants that profoundly shape psychological well-being. Social determinants like socioeconomic status, education, housing, relationships, and cultural context exert significant influence on mental health outcomes. These factors can precipitate or protect against mental distress, illustrating the interplay between environment and individual psychology. Focusing solely on biological aspects risks overlooking critical external stressors like poverty, discrimination, and social isolation that contribute to mental health disparities. Studying social determinants allows for holistic interventions addressing root causes rather than just symptoms. For instance, improving community support and reducing inequality can enhance resilience and access to care. So we are looking at a very holistic view of things, and I think that is only possible through understanding the social determinants of health and mental health. This has been often quoted. This unequal distribution of health damaging experience is not in any sense a natural phenomenon, but is the result of a toxic combination of poor social policies, unfair economic arrangements, where the already well-off and healthy become even richer and the poor, who are already more likely to be ill, become even poorer, and bad politics. So, something which we like to always keep in our mind. There are health-promoting factors that found in one's living and working conditions, such as a distribution of income, wealth, influence, and power, rather than individual risk factors, such as behavioral risk factors or genetics that influence the risk of a disease or vulnerability to disease or injury. The distribution of social determinants are shaped by public policies that reflect the influence of prevailing political ideologies of those governing a jurisdiction. So we know this already: social gradient, stress, early life, social exclusion, work, unemployment, social support, addiction, food, transportation. The key domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, social and community context. So all these are very important for the health and well-being of people. These are clearly related to health outcomes, are closely tied to public policy, and are clearly understandable by the public. They tend to cluster together. For example, those living in poverty also experience numerous other adverse social determinants. The quality and equitable distribution of these social determinants are clearly well below the standards seen in developed nations. WHO Commission, Dr. Mohan has already spoken about this, published a report, Closing Gap. So we have already seen this. And the second major area was distribution of power, money, and resources, public financing of action on the social determinants, economic inequalities, resource depletion, healthy working conditions, gender equity, political empowerment, and a balance of power and prosperity of nations. So these are all part of this very important report. The 2011 World Conference on Social Determinants of Health, delegation from 125 member states. The world has looked upon this issue seriously at various periods of time. Rio Political Declaration on Social Determinants of Health, This declaration involved an affirmation that health inequities are unacceptable and noted that these inequities arise from the societal conditions in which people are born, grow, live, work, and age, including early childhood development, education, economic status, employment, and decent work, housing and environment, and effective prevention and treatment of health problems. The OECD found significant differences among developed nations, even among developed nations in health status indicators, such as life expectancy, infant mortality, incidence of disease, and death from injuries. International labor migration and the policies that attempt to regulate it can also impact the health of not only those that migrate, but their family members who stay behind. We now see a lot of discussion on this, especially with the trade barriers which are confronting our country as well as other nations. International health inequalities. Even in the wealthiest countries, there are economic inequalities in health between the rich and the poor. We have seen this during COVID-19 times. Globalization is a key context for the study of social determinants of health. As a result, there is an uneven distribution of wealth and influence, both within and across national borders, leading to negative impacts on the social determinants of health. So health equity is defined as the absence of unfair and avoidable or remedial differences in health among population groups, defined socially, economically, demographically, or geographically. You can see that the health care and quality, neighborhood and built environment, social and community context, economic stability, education access and quality, these are all important matters for our discussion. There are economic and social conditions that influence individual and group difference in mental health status. So predictors, some of the predictors are socioeconomic status, both a strong predictor of mental health status and a key predictor of mental health inequalities across populations. Socioeconomic status and mental health problems have an inverse relationship. As socioeconomic status decreases, mental health problems increase. It seems clear how the stressors associated with poverty and low socioeconomic status can compromise an individual's ability to maintain a positive sense of well-being and the absence of mental health problems. Socioeconomic status is not only a predictor of development of mental health problems, but also an important determinant of access to positive and proper mental health care and resources. Utilizing proper resources to maintain positive mental health is not only costly and therefore unaffordable for the specific populations, but the resources are also not properly distributed between regions and communities. Communities living in the deepest poverty have the highest need for mental health resources, but have the least amount of access to them. Access means many things, including physical presence of resources, the legitimacy of resources, the affordability of resources if they exist, ability to get to such resources, namely transportation, and level of comfort reaching out to resources due to stigmas. So all these multiple considerations should be coming to our focus. Education disparities. While education and mental health seem mutually exclusive, the parallel between the inequities is incredible. Education disparities can be defined as unjust or unfair differences in educational outcomes that can be a result of difference in treatment of certain minority groups in schools, varying socioeconomic statuses, and varying educational needs. These disparities in education can ultimately lead to issues of mental health. When this happens, less privileged groups get looped into cascading effects of inequality. In mental health care, there is growing unmet need for mental health services and equity in the quality of these services. While these services often advertise themselves as being a support system and caregiver for any and all who need treatment or support, certain aspects of an individual's life, such as race, ethnicity, and sexual orientation, will determine the type of care that they are given. You have seen some of those tragic scenes in the presidential address, so which actually are predictors what is going to happen in the future. And social determinants of mental health and biopsychosocial model, which we often speak about, psychiatrists and other mental health professionals are cognizant of the fact that the etiologies of mental illness and substance use disorders are partly driven by social risk factors. Some psychiatric conditions may have genetic underpinnings that are increasingly understood through ongoing research. Social factors also contribute to risk, although to varying degrees across diagnostic categories and across individuals. biopsychosocial model is formulating both etiology and course outcomes, testifies to the broad recognition of importance of both biological and social factors in shaping behavioral disorders. So you can see this interplay of the biological, social, and the psychological factors and mental health. The biopsychosocial model has served as a structure primarily for clinical formulation of individual patients for several decades, and evidence and support of this approach have increased over time. During the growing focus and research advances on the biological underpinnings of mental illness in recent decades, there has been broad awareness of the simultaneous relevance of biological, psychological, and social factors to the onset and course of mental and physical illness. However, psychiatry has given less attention to those social factors at the societal rather than just the individual level and how these population level societal factors play a role in the epidemiology of behavioral health conditions. So that's in fact, although we recognize, we have given little attention. Global mental health dichotomies divide between a powerful global north and a receiving global south. This division reflected a political argument, epistemological dimensions as to whose knowledge actually counts in the global mental health discourse. Western psychiatry and traditional healing practices engage in an asymmetrical relationship in which traditional local practices have, quote, less resources, social capital, and power because they are traditions of the poorer people. So these are some of the set paradigms which we will have to change, we will have to fight against. The role of psychiatrists and other mental health professionals to promote mental health at the population level and to reduce the risk of mental illness and substance use disorders, psychiatrists and other mental health professionals have a role in altering clinical interventions, implementing and evaluating programs, and advocating for policy change. This work will require new forms of training, because we already mentioned training is so inadequate, quite different from those of the medical model, and it will necessitate working in partnership with the diverse disciplines. Expanding the concept of mental illness from the individual level to public health as a whole is central to the social determinants of mental health framework. Improving health conditions worldwide, reducing the health gap in a generation requires that governments build systems that allows a healthy standard of living where no one should fall below due to circumstances beyond his or her control. Social protection schemes can be instrumental in realizing developmental goals rather than being dependent on achieving those goals. They can be effective ways to reduce poverty and local economies and can benefit. Achieving mental health equality, improving access to health care for underprivileged. The biggest reason why people are not obtaining mental health care is because they cannot afford it. Even the Dean was mentioning some of these things today morning. Also, changing the content of health care to include mental health is equally important. Mental health is still not considered to be main part of basic health care plans. In order for individuals to receive the treatment necessary for mental illness, it must be acknowledged as an illness. Integrating cultural perspectives. The challenge of integrating evidence-based medicine and cultural psychiatry raises a question of methodological, epistemological, and political pluralism. The need to recognize different types of knowledge, namely outcome, should be measured not only in terms of symptom reduction, behavioral change, or level of instrumental functioning, but in terms of individuals' ability to pursue culturally relevant goals, including the impact on the family and community. Social approach to mental illness promotes comprehensive care, regardless of diagnosis and chronicity, seeing patients in the setting of their family through home visits and eclecticism in psychiatry. Social psychiatry will continue as an ideological and practical discipline, not only an ideological, but also a practical discipline. Collaboration is necessary between biological and social psychiatrists so that the advance in social psychiatry can be underpinned by new knowledge of brain functioning and the discoveries of the working, so the brain can be given a meaning through the understanding of the patient's social environment. Julian Leff, as you know, he was one of our speakers at the World Congress in Delhi the year before he died. A tension between, quote, a tension between a neurobiological and societal model has characterized psychiatry since the establishment of academic psychiatry. This tension has been productive and moved psychiatry forward. However, psychiatry may have been at its most attractive as a profession when the societal perspective was fully embraced as central to it. As recently, very recent session, WHO 2021 session, recalling United Nations General Assembly resolution of 2019 entitled quote, Political Declaration of the High-Level Meeting on Universal Health Coverage, unquote, which acknowledges the need to tackle health inequities and inequalities within and among countries through political commitment, policies, and international cooperation, including those that address social, economic, and environmental and other determinants of health. The biomedical model, its limitations. Criticism biomedical focus on the individual level causes misses root social and structural drivers. A paradigm shift is needed towards population health models that include structural determinants. Medical care alone is insufficient to ensure better health outcomes. WHO emphasizes addressing social determinants of health is fundamental to improving health and reducing inequities. Understanding social determinants benefits to clinicians. Mostly when we make social psychiatric presentations, clinicians look the other way. This is theoretical, but definitely there are. Dr. Mohan Issac has also said how your life expectancy can be increased by closing the gap is possible through spending a few minutes extra with your patient. We can apply every aspect of patient's life to their illness. Those with mental illness can now gain a sense of self-awareness. Mental illness sufferers can understand their health as a whole entity with several parts that function together. It also broadens the way we view a mental illness by no longer looking at it as a black or white issue. The biopsychosocial perspective also challenges the stigma on mental illness by enabling people to realize that anyone can suffer from a mental illness because we all have biological, psychological, and social influences in our lives. As we go through life and the environment changes, our brain and its functions also changes. Likewise, a person's genetic makeup and the environment they interact with will have a profound effect on their mental health, biological health, and their brain functions. In order to truly understand someone's mental health, we must take into account all of the factors affecting them both positively and negatively in order to get a better picture of their overall health and well-being. The biopsychosocial model introduces the idea that there are biological, psychological, and social determinants to mental health. This idea links the outside world to someone's biology and psyche. It also involves our consciousness, sentiments, and behaviors. The biopsychosocial model is both a philosophy of clinical care and a practical clinical guide. Philosophically, it is a way of understanding how suffering, disease, and illness are affected by multiple levels of organization, from the societal to the molecular. At the practical level, it is a way of understanding the patient's subjective experiences as an essential contributor to accurate diagnosis, health outcomes, and humane care. So these are some of the events very recently. Here, a couple killed child and commit suicide. You can see that Ajish's parents who alerted the neighbors when they did not open the door. So what happened was there was a financial burden. This man, according to the police, Ajish and his wife, because there was a diagnosis of malignancy. Their financial debt, there was no one to help them, and then there are heartening news as well, although not exactly from psychiatry, but very close to us in our interface. This is a Hindu recently wrote, the Kerala model. Kerala is the only state to develop a globally acclaimed community-led palliative care model. The first initiative was set up in 1993, so I don't want to read. But the most important part is a large network of doctors and nurses supervises over 5,000 patients, possibly the world's most extensive community-run palliative care network, say experts. So these are some of the models which we can always keep in mind. And in conclusion, integrating social determinants into mental health discourse fosters more effective person-centered approaches, acknowledging the complex interplay of factors shaping mental well-being. It encourages policies targeting upstream social factors alongside clinical treatments, promoting prevention and equity. By bridging biological insights with social understanding, we craft comprehensive strategies enhancing mental health outcomes globally, recognizing individuals are embedded in societal contexts, profoundly affecting their psychological lives. This balanced perspective is key to advancing mental health care and reducing global disparities. And I just want to introduce this book. This is a source. Almost all of us have written chapters here, and this has been a project of the social psychiatry. And social determinants of mental health was one of the most important themes in this textbook. And again, this recently published book, I can see almost all here are contributed to the book. Debasis Basu has written a chapter. Professor Mohan has written a chapter. Dr. Rakesh Chaddha has been a chapter. So this has been some of the work we are, our efforts. And of course, you can see that Salman Akhtar is our senior here in PGI. So, and then to close, quote, I and my circumstance. So this is Ortega Gasset. So basically that is our theme. And this is one of the photos which I love, which I took in Lima. So where what I have written in Spanish, Ministerio de Salud, Ministry of Health. Personas que atendemos personas, persons who take care of persons. That is basically our mission. Thank you very much for the patient here.
Thank you very much, sir. Please come and join us here. Professor Roy Abhraham has given a very broad and encompassing overview of why social determinants in this era of biomedical is important. Thank you very much, sir. And now we have, it's my pleasure to introduce another of the stalwarts in psychiatry, Professor Rakesh Chaddha. Again, without going into a very long, and I can tell you these are very short actually, it's not long, but it's a very short CV slide. But essentially, Dr. Chaddha has been instrumental for decades in carrying on teaching in psychiatry in the premier institute of All India Institute, Delhi, and also published many books, many other training materials. He'll always remembered as a great teacher, a tremendous organizer, and has been the president of IASP, as well as the current incoming president of World Association of Social Psychiatry, amongst many other accolades. So without getting into that, rather, sir, we'd like to hear from you about your important topic. Please, Dr. Rakesh Chaddha.
Thank you, chairpersons. After two illuminating talks on the social determinants of mental health, my topic is slightly different and somewhat on the application side, incorporating these determinants in the medical curriculum. It gives me a great pleasure to be here at PGI, and I have fond memories of 1986 ISP conference. At the time I was senior resident, and I think that was my first formal training in coordinating the scientific program under Dr. Savita Malhotra as the chairperson of the scientific subcommittee. So I also had made one presentation in the conference. That was a small gathering, and but I can remember many learnings from that conference. So coming to my topic, this started with the social determinants of health. Nearly 20 years ago, formally the WHO came out with the statement nearly 15 years ago. So as we know that social determinants are the conditions in which people are born, grow, live, work, and age. This recent paper which Dr. Mohan Issac also displayed Social determinants of mental health, they represent the most modifiable set of targets for intervention currently available to prevent the onset of mental health problems and disorders and to promote positive mental health in our population. Now, these are shaped by the distribution of money, power, resources at global, national, and local levels. Medical care alone is insufficient for ensuring better health outcomes, and so on. So I won't go in more detail because this has been discussed. So this is a more formal classification of social determinants of health, which include those in the physical environment, like air quality, water quality, housing, transit, social economic factors, education, employment, income, family and social support, community safety, clinical care. Now, while talking about these factors, it just came into my mind, when any patient comes to psychiatry OPD at PGI, there used to be one proforma which would be filled up by the psychiatric social worker, and which would include all these details. And then the patient would come to the walk-in clinic. So this importance of these factors was recognized by Dr. Vig and Dr. Verma way back in when they designed that proforma and when the formal clinic psychiatric services were started. Now, when we talk about relevant social determinants of mental health and mental disorders, it's important to know that nearly 50% of the cases of severe mental illnesses have onset by the age of 14 and 3/4 by the age of 24, and treatment is often delayed by many years. We all are conversant with this issue. And for median age of onset of anxiety disorders and impulse disorder is 11, they're further lower. And same way with the substance use disorders. So this early onset of mental disorders that severely impact the quality of education, further job opportunities, and leads to poorer healthcare access. And so that's how the social demographic factors are very important in etiology as well as access to treatment and later recovery. Coming to specific social determinants of mental health. Now, there's a big overlap between the social determinants of health as well as of mental health, but if we go into specifically social determinants of mental health, so starting with the socioeconomic factors like income, employment, education, housing, transportation, food scarcity, accessibility of healthcare. Then come the familial factors, social support, which is a very important component, which affects treatment seeking as well as the prognosis, caregiver separation, families and childhood adversity, loneliness, social isolation, then the cultural factors like linguistic barriers, neighborhood factors, social and physical conditions, housing, instability, structural and historical factors like migration, discrimination, and educational factors like unmet educational needs. This is further a diagrammatic representation. They start with the public policies and the social norms, which affects the distribution of opportunity, then leading to factors like unemployment or underemployment, food insecurity, poor built environment, housing insecurity, leading to reduced options, poor choices, high risk behaviors, further increasing and leading to the poor mental health. And so social determinants of mental health, they start from the prenatal period and early childhood and go through the childhood, adolescence, adulthood, and older adulthood. Like culture, community, family, these are the different groups, low socioeconomic status, poor housing. This would be affecting from the prenatal period, and this continues throughout the life cycle. Now, what are the reasons for lack of emphasis on social aspects of medicine? Now, this is my core title on which I have to speak. I have been asked to speak. In teaching and research, focus is often on technological development, and social factors, they are often get the back seat. Research into biological or physical factors appear more glamorous and innovative. You apply for grant to any funding agency, ICMR, DST, DBT. Chances for any proposal which deals with which is focused on social factors, chances of getting grants are very, very bleak. Just the day before, ICMR has released the list of the projects which they have awarded recently. I don't think even a single project is there out of those 30, 40 who have been, which have been given grants. The student also tends to ignore social factors because they are not considered, they feel that there's nothing new in it, there's no attraction, and this leads to lack of attention on the social factor, and the role is often ignored. And in the rapid pace of modern life, the medical professionals also further tend to ignore the social aspect because they look less glamorous. So, thus there are a number of barriers to addressing social determinants of mental health in persons with mental disorders. Focus is often on diagnosis. Nobody wants to talk to the patient about the social background. In fact, in the last 1.5 years, I joined another place after retirement, Amrita Institute of Amrita Hospital, Faridabad. And the moment I asked, because the patients at AIMS, the situation was probably different. Here, if I start asking the patient details about from where he or she has come, or say, what does he do? And one patient started ask me whether you're looking for a house in that area. So that's the way people think if you start asking about the social details, why the doctor is interested in me. Fortunately, nobody asked whether you're looking for a marital aspect for your child, your son or daughter. So there's focus on diagnosis. There are weak linkages with the social services. There's a lack of training for the students, trainees in the social determinants of health. Healthcare finances are more focused on the physical treatment or say medical treatment, and there will be less and less focus on the providing education or say awareness activities, and there is low research funding for social determinants for mental health. Now, how we can incorporate social determinants in medical curriculum? Emphasis has to be on holistic approach to patient care. The WHO way back 1948 came with the definition of health. Social was one of the three components of health. So incorporation of social determinants of mental health can help in bringing a holistic view in patient care, since one would also be focusing on socioeconomic status, income, education, employment, environmental factors like housing, neighborhood, green spaces, access to green spaces. Now, this is also one of the very critical area to, like Chandigarh used to have large green spaces. Even now, it has large green spaces. The traffic has overgrown. Just few days ago, I was reading somewhere, there was a big criticism of Le Corbusier that Chandigarh is not a good planned city. Reason being, it's not providing habitat to a larger population. So that kind of criticism is also sometimes comes, though it's taken as one of the modern cities, though overgrown. Social environment includes social support networks, exposure to discrimination or violence, healthcare access and quality. So these are some of the very important social determinants of mental health. So what would be the steps of at integration in teaching? Development of dedicated modules or courses in social determinants of mental health, integrating these concepts throughout the entire medical curriculum. Teaching methods need to include didactic sessions, not simple lectures, workshops, reflective practice, and experiential learning opportunities like community engagement and home visits. Home visits, I very well remember 1976 when I joined MBBS at Rohtak. Even in our first month, we were taken to the residential campus, and we are given some forms and to fill up the family details of the, we were allocated each student was allocated 2-3 houses. So that was a kind of thing. And these are the students, they don't want to come for even leave aside psychiatry. They are not coming for any clinical postings, and they start preparing for postgraduate exams starting from their second year. So liaison with the regulatory authorities like in India, National Medical Commission, National Board of Examination, that would be very important, that's necessary. What could be the advantages of introducing social determinants of mental health in medical curriculum? The future physician will be better able to understand the complex interplay between social factors and mental health, leading to more empathetic and comprehensive patient care, moving beyond simply blaming patient for their health issues to recognizing the systemic factors influencing their well-being, identifying and addressing barriers to treatment. Now, these are three very important factors, 3 A's, that the affordability of the treatment, accessibility of the treatment facilities, and acceptability of the treatment. Recognizing and addressing health inequities faced by the vulnerable populations, developing greater empathy and compassion for patients facing social challenges, and becoming more self-aware of their own biases. The students need to become self-aware of their own biases, and preconceived, they need to challenge their preconceived notions about patients from different backgrounds. Now, there are big challenges. Even way back when the NMC had come out with a new curriculum, that's before the competency-based curriculum, around 2009 or 10, there was a big major revision. And there was only one psychiatry expert was called. 3 were probably called, and 2 probably did not go for the meeting. And this one person, he or she said that there is a no need to further expand the psychiatric curriculum beyond 10 or 12 lectures what were there. And when we came to know, I, Dr. Chavan, Dr. Khandelwal, from IPS we went, and there was in fact very bitter arguments with the MCI. At that time it was MCI, and so they said, no, this will put extra pressure on the student. How can you expand the psychiatric curriculum? And there was there can't be a separate exam. So there was big resistance. Fortunately, when this competency-based curriculum was being designed, 3 of us were there, me and 2 other senior psychiatrists from different parts of the country, and we were given 2 days, and psychiatry was given the equal level of status as the other minor specialties like dermatology and other. So, but curricular overload, that remains one of the biggest challenge. Medical curricular already packed, making it difficult to allocate sufficient time for social determinants of mental health in education. This lack of faculty training, which also needs to be sensitized with the necessary expertise and training to teach social determinants of mental health. There's a lack of standardization and inconsistent teaching approaches and evaluation methods for social determinants of mental health training pose challenges, and there are limited resources and funding. Some of the recommendations for effective integration include longitudinal approach, implementing social determinants of mental health education throughout the entire medical curriculum, allowing for increasing complexities of learning objectives, experiential learning, interprofessional collaboration, faculty development. The faculty also needs to be provided with the necessary training and resources to effectively teach social determinants of mental health, addressing potential knowledge gaps, and assessment strategies, developing appropriate assessment methods that evaluate students' knowledge, skills, and attitudes regarding the social determinants of mental health. There have been some recent studies also which have evaluated how social determinants of mental health have been introduced in the different parts of the world. Most of these studies, they are from the Western countries. One of the study on social determinants of mental health in child and adolescent psychiatric fellowships. It was found that 98% of the program directors felt education on social determinants of mental health was essential. No, people feel this is essential. Familial factors rated as significantly more important than the structural, historical, and economic factors. Structural and historical factors were viewed as being taught less effectively. There's another review, a scoping review of social determinants of health in postgraduate medical education. There were 12 studies identified, all from US. Most curricula improved participant-related outcomes. Program-specific outcomes were frequently positive. Resident satisfaction and high course evaluation scores, high representation of residents and faculty from minority groups. Academic outcomes were always positive, included presentations in national conferences, publication of research work, grants earned to support health projects. This review is from Japan, in which 4-week mandatory clinical clerkship in medicine and primary care at one of the university schools was provided to all 5th and 6th year medical students. Students' understanding of social determinants of health strengthened as the social determinants of health program in CBME curriculum improved. This was another study which has recently appeared in the 2024 in the BMC journal. A systematic 24 studies were identified. Most were from the developed countries, USA, 22 from USA, 1 from Canada, and only 1 from Kenya. This is a 9-month pilot course at Philadelphia, a relatively old study. Now, what is the status across the globe? Some curricula deal only with specific social determinants of health, such as homelessness, poverty, or race, and do not use the larger umbrella term. There are varied terms used, such as population health, community-based care, service learning, marginalization and vulnerability, social justice, and advocacy. There's a little evidence that teaching social determinants of health does anything to alleviate inequity. Although educational models are useful to teach complex ideas like social determinants of health, there's considerable heterogeneity across projects. Most do not involve community members in identifying the local health priorities. The current approach to social determinants of health within medical education positions social determinants of health as a facts to be known rather than as condition to be challenged and changed. This needs to be integrated throughout the training, but even this may be insufficient to create critically conscious physicians or to make such progress to achieve equity for patients. The educational mandate of training institution needs to shift from developing competent and socially accountable physicians to training doctor citizens. So that's the thing which is important, which we need to achieve. And there's a need to restructure medical education to train critically conscious, engaged physician citizens who could change the physician-patient and physician-society dynamics in meaningful ways. So to conclude, the social determinants of mental health, though known since long, have not been given due significance. Recent emphasis by the WHO by giving it a proper definition and recognizing its significance has brought focus on it. There's a need for its recognition by health planners, society, and health educationists. And there's a need for inclusion and due emphasis in the medical, nursing, and related curriculums to improve the health status of the society. Thank you. Thanks for your kind attention.
Thank you very much, sir. With this, we'll move on to the last presentation of the symposium, for which we have Dr. R. Srinivas Murthy. Dr. Murthy has been working in the field of community and social psychiatry for nearly half a century now, if I'm not wrong. I have a personal pleasure of introducing him because he was my MD examiner. Sir needs no introduction also. And I think since we are approaching lunchtime, I would request sir to start with his presentation. Over to you, sir. I think we are all waiting to hear from you because the title is also involving action.
Thank you very much, chairpersons, dignitaries.
And if I may just add one more word, sir, that this is going to be the last presentation before the lunch, but as they say, it's last but not the least, because I know it's going to be a power-packed and a very important presentation. Dr. Srinivas Murthy.
Thank you for raising expectations in a hypoglycemic state. No, for me, coming and standing here is very, very personal. In North India, it said going to Maike is always a pleasure. So to me, PJ is my Maike, and that's my home. And I finished psychiatry here 50 years back in 1975. What I want to do in the next 20 minutes or so is to present to you a very positive aspect of the social determinants of mental health from evidence to action. I handle it here? Yeah. Right now, there is a lot of attention to mental health. In point of fact, next week, the General Assembly of United Nations is discussing, and in preparation for that, there are two documents released by WHO, this and this one just this week, both giving an update on the things. Actually, the love of mental health started in 1959 when the first World Mental Health Day was celebrated. Then the 1975 report on Organization of Mental Health Services, of which Professor Wigg was the rapporteur. And then I was associated with this report, then to 22 report. So there is a lot of talk. But I didn't put that slide. I noticed that the statement made in 1959 and 2025 by the Director General is the same. Mental health is important. It is neglected. Nothing is being done. I want to present to you a possibility of something being done in this area. Luckily for us, not only that we are discussing here the World Federation of Mental Health, next month or so, the World Psychiatric Association, the IPS is talking about unshackling psychiatry for society's mental health. Then the World Social Psychiatry in Casablanca is going to discuss. All of them are talking about social determinants of health. And the Lancet Citizenship Committee had a very big workshop on reflections on workplace in mental health. So everyone is talking about it. Why is it? The reason is that all over the world, particularly in India, lots of social interventions have been done. These are all from the political area, Jan Dhan account, the Griha Lakshmi program and other things. So in the mental health area, I thought I will focus upon what can be done, what is possible to be done. For all of you, I looked at the total program and I find there are 4 other speakers speaking on the same topic, about a dozen symposia, a dozen papers and posters. So all of you are going to get a lot of information in this area. So my presentation is going to be, is there any historical evidence for social psychiatry being a powerful tool? Second, what are the recent social interventions for mental health in India which we can use it as a model? What are the priority areas? And can we, as individual mental health professionals, departments, institutions, NGOs, and associations and government do what can be done at each of these levels? And lastly, going by the way everyone has presented in the last morning, what are the barriers to action? The biggest barriers being all of us sitting here. I'll come to that last. As Roy pointed out, this is a fantastic book. I would suggest that each one of you, the 1,200 rupees you will spend will be worth it, because there are 12 personalities, social psychiatrists, and their life being presented in a great detail, in a very analytical manner. I had the privilege of writing the foreword, so I had to read it everything. And there are another 20 or so brief write-ups of social psychiatrists. And because of time, I'll just mention 3. Just think of the change that Durkheim brought about, one of the the beacons of social psychiatry. He converted suicide, which was thought of as sin by the religious people, to a social issue from looking at the data from the church records. Similarly, Julian Leff expressed emotion. A clinical issue of relapse was converted into a social action program of family interventions. All of you know it, so I'm not going into details. And Margaret Mead said culture influences character, temperament, and personality as much as biology. So you can find enormous amount of literature. I would say it is a must read for every one of you. Coming to actions in the current one, the best I can present to you are from Chandigarh. Dr. Vig came back after working with WHO in 1980, when he completed 60 years, 1990, 60 years from WHO. And since I knew him from 1972, I know he said, there are 2 things which I'm going to do as a psychiatrist to make a difference. Both of them were not clinical, in the sense that setting up a clinic or running a things. He said, I will write a column for the Tribune. And this book, which is available from the Servants of India Society in Sector 11, get hold of it. You cannot find a better book of public education than this book. There is particularly one chapter on Vanaprastha, which I am working upon. I'll come to that in a minute. So public education is something which Dr. Vig demonstrated. Not only he did that, he sat in Servants of India Center for 2 days every week to provide free service to anyone who wanted to come. And he has written about his 25 years of experience, and do read it. The second person from Chandigarh, there are lots of people, but I'm just focusing up on a few, is Dr. Chavan. Remarkable person. Next to Dr. Vig, I have not met anyone more influenced me than Dr. Chavan. That's one of the reasons why Dr. Nitin and myself brought out this 400-page book, which is available free of cost to all of you. I saw him for the first time in 2008, when in the IASP conference in New Delhi, he walked up to the stage and started describing what he's doing in Chandigarh in the area of social psychiatry. I said, this is not possible. Because he was describing things about a caregiver group, he was talking about a kiosk for the disabled, he talked about halfway home, all the things that I thought we should be doing it, which is not being done. And then we became good friends, visited many times, and it's a very big loss for all of us. And you read the book and you will find from all over the India, lots of interventions that are occurring in social psychiatry. Few more, not because it's comprehensive list of it, I've just chosen some of them. Just think of Nimhan's director sitting in Lal Bagh and talking to a group of youth people, not about mental disorders, but mental health. Similarly, just think of what it means. This is Dr. Pratima Murthy, who is sitting there. This is in Lal Bagh. This is an invited activity. Lal Bagh is the biggest, it's about 100-acre garden where this is occurring, and it's occurring every month. Not one day, every month it's occurring. Similarly, another colleague found that digital addiction is a problem. Instead of talking about only the problem, he said we will develop a parent group technology. Addiction gets to about 5. 2 parents will address the parents how they can take care of the children rather than the children with the problems. They started with a 4 or 6 week program on weekends. Then because of the demand, they reduced it to 2. The point which I'm making is it is possible to reach out. More than anything else, just think of the sheer magnitude of what Prime Minister Modi does every year, Pariksha Pe Charcha. You know, you can spend a whole day, if you have not looked at it, look at every single mental health issue was addressed by him, and he's doing it every day, and it is making a difference. In many states, programs are being developed, like in Kerala, they are developing specific programs for elderly. I won't go into details. More important than that, a very big resource that we have in our country is the caregivers. You know, this is from the director of NIMH for about 20 years, who wrote a book. In America, when the mental hospital beds came down, the number of people in the jails went up. It's a very significant diagram. In India, this has not happened. In point of fact, just last month, Outlook, Alok Sarin has written a very important article on where he's talking about the neglect of the need for institutional care as follows. It is up to us to balance the two opposite things to ensure that end of the day, people who need access to affordable, accessible, reliable care occurs, and this, we need to make a good success of this mix. Similarly, Dr. Kala, 2 days back in Madras, where he was given the Desiraju for award, talked about the need for institutional care. But, and about 3 days back, this conference was held in Pune. I was able to join virtually, where there were about 7 NGOs who came up and talked about their own experiences of supporting each other. Similarly, agencies which are developing innovative programs talked about it. Unfortunately, I must say this to all of us who are sitting here, there are 2 parent groups. One is called Mission, other one is called Eminent. Luckily, because of my interest, though I am not a parent or a, they include me, so I follow their WhatsApp group. The first one, Mission, has 350 people. Second one has got 100. What are the 3 things that are missing? They are talking about what Dr. Chaddha talked about: affordability, accessibility, and acceptability. We are failing in all 3 of them. They say you are very unaffordable. You are not accessible. Repeatedly issues come up and you read it and you say, my God, what is happening to us psychiatrists? And more than that, there is a tremendous amount of hostility to us. We are not acceptable. I'm sorry to say that. Even my inclusion was mainly because Amrit Bakshi and another person said, look, Murthy should be there because he is our man. So we have the biggest possibility of change by working with the caregivers in this way. Now, one other example. 10 years back, 2 young people, Richa Singh and Puneet, were working in Indian Institute of Management, Guwahati. One of their friends committed suicide. They came to Bangalore and started this startup called Your Those. And they met me at that time, and again, I saw them last week in preparation for this. Can you believe they have now 200 staff working with them, about 1,000 professionals online, and they have 500 organizations asking them to help with promotion of mental health. If you want, go into them, read them, or I will put you in touch with them. So it is not just a need, it is a practical need which can be made into an affordable need or an economically viable need. I can tell you any more number of examples, but I think time is running out, so I must quickly add to what we can do. The priorities for me for social determinants is youth mental health. All of you know about the Supreme Court committee. I mean, remarkable thing. Supreme Court has put out a website asking parents, students, professionals, media, the politicians, anyone and everyone, a Google survey map where you can fill up and they are looking for a solution. Remarkable that was. And the guideline they issued last month is there. Caregiver, I have already emphasized it. Please, please, this is the biggest resource that we have in India. Economic inequalities like poverty, commercial determinants, my colleagues have talked about it. Another area where we have a big challenge in India, all over the world, but in India, is gender inequality. We must work not only with women and legislation, but with men changing their attitude, then addiction and healthy aging. Again, a big issue. Aging is something which everyone is struggling with it, and I will conclude with my example. India has the solution to healthy aging, and we need to make it happen. Dr. Pratap Sharan, in one of the IPS groups, said this when a topic came up about marginalized population. It may be a good idea to form a group that explores ways of taking up these challenges beyond debate to praxis in India. Beyond debate to praxis in India. That is the topic which I will cover in this one. So what can we do? Sometimes we'll say that, look, the problems are so big. And Dr. Rakesh Chaddha said just a few minutes back, little evidence that teaching SDOH does anything to alleviate inequality. I personally want to say, no, it is not true. We can make a difference, and here are the examples. As individual professionals, as Mohan pointed out very, very strongly, we must move beyond clinical symptoms to lifestyle situation. There is enormous amount of evidence. Do you know that last year, American Psychiatric Association, Mr. Venkatraman said, look, lifestyle psychiatry is the motto for 1 full year. Similarly, other people, for example, when I was working with cancer, I developed a card, one called My Emotional Health, My Choice, where I put down 10 things that people can do to take care of themselves. And I have a blog post called My Emotional Health. So each one of us should make in our clinic not only a clinical care, a lifestyle intervention. Have poster about exercise, sleep, nutrition, meditation, connectedness. Inquire about that and tell them that doing these things, and as Mohan said, this month's paper, Lancet, which is a free download, you read it and you sign that lifestyle interventions are as practicable, as effective, even in severe mental disorders. And the other thing which we all have to do is to reach out to vulnerable groups. It could be migrants, it could be elderly people, it could be slum dwellers, and tell them about what they can do to strengthen themselves. There are things which each one of us can do to strengthen ourselves, and we must share this one. Then document your successes, and most important, all of this is local. SDOH is local, not universal, and we must identify cultural resources for mental health. As departments of psychiatry, we must document cultural practices in addition to the individual things. Train all persons about as much about mental health as you do for mental disorders. Set up support groups for caregivers, elders, youth, vulnerable groups, so that you are seen as a mental health center, not a department of psychiatry. What we are doing, forgive me for using a very bad example, what we are doing is not running beauty clinics, ugly people's clinics. Who will go to an ugly people clinics? Beauty clinics, everyone wants to go. We must make psychiatry, I believe in it, and it's possible to do that. And of course, we have to do research and evaluate. Similarly, mental health institutions will have to take up bigger issues of policy and other things. The non-governmental organizations can be very good in innovation. I was hoping to talk about Banyan, who 2 young girls 30 years back looked at homeless mentally ill and made it into a 7-state program with enormous things. And both of their papers are there in Dr. Chavan's book. The associations. I'm sorry to say that we have failed miserably. Exactly 13 years back, when Dr. Avdesh was the president of the Indian Association of Private Psychiatry, he invited me as one of the gurus. I made a presentation similar to this, saying that we must become accessible, acceptable, and become the source for the community to think of mental health. Let us become the lighthouse for the public by having a website where information is given to them in a manner that they can use it, opportunity for them to ask us with problems, something like what I told you about Mission and Amend WhatsApp groups. I've talked about it again and again. We seem to be not interested in it. It is again not only the national IPS or IAAP or IASP, but it should be local with lots of local material, local examples, so that people say, hey, this profession is reaching out to me. And if you see, whether it's the AMAHA, IMAHA, they are trying to take over these top places which is legitimately belongs to us. Then we should have a dialogue with the government and other things. Lastly, government, of course, will have to develop the policies, programs, and legislation to make all these things happen. What are the barriers? There are a couple of barriers. I'm not saying everything is easy, just wish it and everything will become all right. The biggest barrier is that we must look at this situation with the local lens rather than the universal lens. Because I remember now in Latur, when 1993 earthquake occurred, Dr. Hari Shetty, we were all working on it, Mohan Agashe. People are not willing to express grief. Then someone said, let's have a session of Haldi Kumkum festival or something like that, which is a traditional way of doing it, and it provided the breakthrough. Much more than our saying that you must have counseling or you must come to that. So local documentation, local identification of both the positive and negatives, and we have a big professional reservation. We talk about everything, but we end up wanting to be clinical. I will give you 2 examples and close my talk. And there is a complex nature of it. There is a need to work with other professionals, time frame, long time frame, and measurement issues. The point with this is from the 2001 World Health Report. All of us have been very good at this. We spent a lot of time, nearly 3 months to develop this diagram. We said, look, all what we need to do is to work upon that. Just tell you, even in 2001, when I was working with WHO for this report, the WHO was not willing to accept this as the thing and said, look, that's why we ended up saying mental health in primary health care as the message. Even in 2022, it is still the services, but our solution from all public health examples, whether it's cholera, whether it's COVID, is when you stop the problems at this stage. Let me give you 2 examples and close my talk. Last year, on the IPS day, there was a symposium on the foundation day called Sound Body in Sound Mind. Following that, they brought out this calendar where every month had a theme. Just look at it. Gambling, kleptomania, all clinical syndrome, trichotillomania, nothing about mental health, nothing about social determinants. This is the dichotomy that we have. And I wrote to them and they didn't even reply to me. The point which I'm making is we are living in a schizophrenic type of an approach to our profession. Second one. 2 days back, Dr. Savita was there as the chairperson of the president of the IPS. There was a symposium on suicide prevention. 2 brilliant presentations by Vijay Kumar, Lakshmi Vijay Kumar and Hari Shetty. 2 topics they didn't touch. Spirituality and positive mental health. They didn't touch it at all. I have a recording of it, I can tell you. Why? Because the book, this is the Oxford textbook of Suicidology, Social Prevention, 2023. The first 11 chapters are on suicide, spirituality and suicide. First 11 chapters, and because Dr. Danita Wasserman, who was the chairperson, who was the editor of the book, said, look, spirituality is the best inoculation for suicide. And we don't talk about it, we don't mention about it. Similarly, I told you this was a fantastic the thing. It's available in Mittal, this one. Dr. Saxena and Dr. Mittal, Dr. Vikram Patel were psychiatrists. There was someone from Indian Institute of Management, Ahmedabad, some from Delhi, and from another, the Seva from Ahmedabad Foundation. These 3 ladies talked about social determinants of mental health. While, forgive me for saying it, these 2 were talking about downsizing, training lower level workers against services. You know, somehow I can go on and on, but I'm going to close it. But luckily for us, we have in us a very big resource in our country, spirituality. I'm not saying it here. 1954, when All India Institute of Mental Health was found, they chose Samatva Yoga Uchayate. That means equanimity is the goal of all existence as the motto for mental health. I am saying to you, like it has happened in 2014 for yoga, 2024 for meditation, in the next 5 years, you're going to see a World Day for equanimity. And if we can convert this idea of equanimity, not from a philosophy, but a practice, then we will be giving the biggest contribution to the world. In point of fact, this is something which each one of us can do it. So, coming to the end of my presentation, rain will always be there. This is something which I see every day when I go for a walk in my mini forest. There will be an umbrella. All of us are providing the umbrella of survey case. But recharging the water is what we should do. And in mental health, I hold the view, after 50 years of work, that we can promote mental health, prevent mental disorders, and make a difference to the mentally ill. Lastly, I'm devoting my whole of this year, with the support of Dalai Lama Foundation, to develop spiritual approaches to aging well, not as a philosophy, but as a practice. Thank you very much.
Thank you so much, sir, for that extremely passionate, well-informed, but most importantly, inspiring talk. As I had promised everyone that this is going to be last but not the least before the lunch. I had already predicted this, that it's going to, and you have really kept up to that promise, sir. And all four of you, I have no words of to praise. And it's not just the praise. I think it's important that the four speakers have talked about four different aspects complementing each other, overlapping, but different aspects of social determinants of mental health. And together, how one can possibly make a difference. Okay, so with this now, we still have some time. We have about 15 minutes or so for questions from the audience. Questions or comments, anything. It's not necessarily a question. Comments also are welcome. And at the same time, then I will request later on, or when we have a gap in between, when the silence, then maybe to, for the speakers, because they are so eminent with their experience, maybe to comment on perhaps each other's talk as well, because I think that's important. I was telling Dr. Mohan, Issac, when Dr. Rakesh Chaddha was presenting that very important thing about curriculum, training, etc., to make a few comments. We'll come to that, but let's take a few comments, questions, clarifications from the hall, please.
It's very nice to say that the lifestyle problems are a real serious problem around the world. But the real problem for clinicians is that it is easier to treat the life problems of the patient than the persons who accompany the patient, that is the family members. We very often see the mother very obese, maybe more than 100 kg, or the father or the brother, but we can't do anything about it. So this is a very practical problem because we are not there to advise the normal people, so-called normal people. We are only for the patients.
I'm really grateful to all these presentations. And there's a little submission coming from my side. I'm from Psychology Department.
Okay. Yeah, if you can kindly introduce yourself, ma'am.
Yeah, this is Professor Harpreet Chaddha. I've been Chairperson Psychology Department, Punjab University, Chandigarh. I am observing that in the schools, the children are getting very anxious after this COVID. And they've been so much in touch with each other through, internet and all, even for their assignments. Now, such cases are coming to the hospitals. They are getting admitted in GMCH 32 also and PGI also, where kids are having, being given injections against anxiety. And so the peers are also involved in it. I really would urge this particular association to bring in some kind of set of modules for the peers of these children also. Because parents are in a quandary. They are having a problem, how to handle the peer group. They have to give some kind of a socialization to the child. The child may not be a child, a 16-year-old who has a very good business at the back, even so. So that's what I observe and that's what I feel. There has to be something encompassing the peers also. Thank you.
introducing social determinants of mental health in the medical curriculum, so that the medical trainees, they are well sensitized to this issue, and every psychological issue or any mental health issue should not be given a medical diagnosis and treatment, and there are methods, psychological method, non-pharmacological methods to deal with those issues.
Thank you. Dr. Srinivas, Murthy, any further and then we'll come
I just want to respond to what Professor Indra Sharma talked about lifestyle things. Two examples I want to give you. First example was I started providing my services to a cancer center. When I went there, there was already a psychiatrist, senior psychiatrist. He said, "Why are you coming? No one comes here. No one keeps up the appointments." Then I told him that you are expecting a person with cancer to come looking for a psychiatric help. You need to develop methods which help them. So what I did was to go down to their chemotherapy centers, ask them, how has your life changed? What has helped you? And they brought up issues, what has helped, and most of the time it was spirituality, and built upon that a whole program of taking care of self from their point of view, that if you do these things, you can live longer, you can decrease the side effects. All of this is evidence-based. See, the point is that instead of prescribing it as a discipline, but you have to prescribe it as something which helps. The second example was caregivers. When we are working with the caregivers, 50% of the caregivers of special children have psychiatric problems of significance. When we asked them, they said, no, I want to live for my child. So we built upon that, I want to live for my child, and built up a lifestyle and a distress things. We have written about it, published manuals, and we'll be happy to share with you. So it's always possible to convert the idea. When I told them that by doing this exercise, sleep, diet, connectionness, and meditation, you can live 10 years longer, tell me. And they all came for the workshop, and they adopted it. But if you say, why don't you do this, why don't you do that? So I think it's very important to understand the context in which the distress is occurring and present the solution from that point of view. The same way McDonald's made a vegetarian things because it was needed in India. Thank you.
Thank you very much, sir. Dr. U.C. Garg, please. Very important comments. Yes. Yes, sir.
Thank you very much, sir, for giving a very informative lecture, Dr. Murthy. When we talk about the spirituality, immediately the religion comes in the mind. And when religion comes in the mind, then the gurus come. So this is the dilemma in our practice, that when we talk about the spirituality, the people ask about the religion and other things related with different gurus and all these things. So what is your comment, sir?
Can I come back a little later?
Okay.
I'll come back, I'll answer that. Otherwise we'll
Come
talk.
back. By that time, let's...
Because I don't want to dominate because there are other speakers.
No, sure, sir. Thank you so much. Dr. Neeraj Gill, please, and followed by Dr. Yes.
Thank you, Debashish, and thank you everyone for this wonderful session. I'm Neeraj Gill. Yeah, I'm Neeraj Gill. I'm a psychiatrist and professor of psychiatry in Gold Coast, Australia. My question is about social media as a social determinant of mental health. So generally we talk about social determinants in terms of inequities and poverty and housing and things that we've talked about. But a lot of young people, the Gen Z, they live a lot of their life on social media these days, Instagram and Snapchat and TikTok and all of those. I'm asking because for the Royal Australian New Zealand College of Psychiatrists, I'm on a working group for a position statement on social determinants. And we thought whether we should talk about social media, and we couldn't find a lot written. We could find a lot written on social media, but not in terms of one of the social determinants of mental health. So should we be talking more about social media as a social determinant of mental health, especially for young people, but also for adults and even older people?
Okay, thank you. Very thoughtful question. Maybe we can have a couple more questions and comments, and till such time, then the speakers can also respond. Ma'am, Dr. Savita Malhotra, followed by Dr. Rajiv Gupta also.
I'm just saying that the reason for disconnect between what psychiatrists do and what they ought to be doing, one of which is that psychiatry is taught and understood as science of mental illness. It's not science of mental wellness. We are not trained in the science of mental wellness. And wellness is an illness. These are kind of two different kind of aspects. Although they coexist, every mentally ill person also has a mentally healthy component, and every so-called normal person may have some kind of idiosyncrasies and some kind of elements of behavioral, what can be excesses or difficulties. What is happening is that the scope of practice and discipline is changing, has changed. From illness, now we are reaching to the social psychological factors, to wellness. So I think our training has to change and must sort of reorient itself. And that's what I always say, that we need to rethink and reposition psychiatry.
Question about social media.
I just have one small question or a comment to Dr. Murthy. The last slide, what Dr. Murthy said regarding spirituality. And spirituality in India, we talk that it is a very good reservoir for us. But when you say that you are dedicating this year for old age, I think we have to introduce spirituality at a very young age. That is the real gap. We start talking of spirituality and after very late, say, 5th decade or 6th decade. We have to start instituting this spirituality at a very young age so that it can benefit. So that is my question. How we'll do it, that's again.
Yeah, thank you very much. I think I'll take your question also, sir. Just 1 second. So we have 3 questions so far. Questions come comments, so that before we have to get back to them also, keeping conscious of the time. So the spirituality related questions, I'll request Dr. Srinivas Murthy to take up. The training related question, I'll request Dr. Chaddha to take up. And the mental wellness, I think Dr. Roy Abhraham. And we'd like to have some closing comments, maybe overview from Dr. Mohan Issac also, because then we have to be conscious of time. Yes,
So, regarding social media, the upheaval in Nepal and Bangladesh wouldn't have been possible had it not been for social media. Agreed? And in Indian society, we have a deeply rooted caste system which we fail to ignore.
Thank you.
Thank you.
Thank you for your comments. I think we can come back to.
I start with that?
Yes, please.
Thank you. Thank you very much. The point which Dr. Savita made about our training is at fault. I agree with you on that. That's why I said the departments, institutions have an important role to play, and we should get involved. And I gave you the example of Nimmans, not because I worked there for 22 years. It is really reaching out in the Lal Bagh, reaching out to the parents. Just 2 days back, I couldn't put it in the slides. Dr. Mohan was in a panel where they have developed an intervention for attempted suicide and showed that the repeat suicide is reduced to as low as 1.9% in a 15-month follow-up. Dr. Mohan will probably talk about that more than me. The issue is I am dedicating to 1 year of my life to understand the philosophies in different religions and how it can be converted into practice. I agree with you that it should be started very early as a part of the things. The point which I'm making is many of us are blind to it, to their potential. To illustrate the point, Carstairs, who is a very dear friend of India and wrote about Two Lives book and other things, wrote in 1982 saying that there is no evidence for spirituality and all the yoga and other things. It is there in the British Journal of Psychiatry. But today we know that there is enormous amount of evidence to show that. So the point which we need to convert the ideas into actions. Let me give you 2 examples of that in that, and with that I'll close it. For example, do you know that they did a study of 65-year-old nurses and followed them up for 10 years and rated their level of gratitude capacity at 65, and there was a 30% benefit of reducing cardiac problems at the end of 10 years. Similarly, in cancer patients, if you introduce forgiveness as an important part of the treatment process, your survival increases, your side effects become less, and your mental health problems less. I can give you any number of examples in that. And so what we need to do is to present the ideas not as a book prescription, but as a practice which will make a difference to them in their life situation. That is a challenge. There is a challenge in that, and all of us will have to work on that to make it acceptable to the population. Thank you very much.
Thank you. There has been one major initiative in the last few years. As a student, the new session starts. In the initial orientation, a lecture or say sensitization program on mental health has been introduced by the Medical Council of India and now the National Medical Commission. So that's one of the very important initiatives where the students on the day 1 or day 2 or say within the first week, day 1 is a initial introduction to the whole faculty, all the departments, HODs, and then there are 3 to 4 hour sessions on mental health, taking care of mental health, communication skills. So that's in the first week of the students joining, they get some orientation to mental health, that there is something like this. And unfortunately, this is not continued over the period because I don't know why, because the students, they don't like to come for the clinical posting or especially or the psychiatry and many other minor disciplines. Reason being there is not much inclusion in their final examinations. So that acts as one of the inhibitory factors. And I see students coming for consultations at different times so that's the impact of this initial lectures, initial sensitization program of the first 1 week. So we need more emphasis from the faculty, or the other departments, also other disciplines, that they introduce these angles, the principles of social determinants, because you need to have the biopsychosocial model in management of all medical illnesses, be it hypertension, lifestyle diseases, or say even in infections, like accessibility or availability of the treatment. So there are a number of issues with social determinants which would affect all illnesses. So this emphasis needs to come only from not from the psychiatry, that needs to become from all disciplines. Thank you.
When we speak about mental wellness, I think we should not forget about the power of collaboration. So collaboration in mental health, there are so many other people who can help us, work along with us, families, carers, as well as lay volunteers, especially the non-governmental organizations. I had been fortunate enough to be in collaboration with such organizations for nearly 3-4 decades. And in 2008, I was in charge of when I was professor in Kottayam Medical College, I was in charge of the Idukki District Mental Health Program. At that time, I had invited Prof. Srinivas to make a visit. And then I had an unscheduled visit to one of these centers for severe mental illness people being cared for by lay volunteers. I was having a lot of trepidation. What will Dr. Murthy say? Will he be getting angry with me? Finally, once he came, he said, "Roy, you are doing such tremendous work." And then from then onwards, we could bring in all our postgraduate students and medical students to work there and see those patients. And when I had a meeting with the Chief Minister of Kerala, he said, "I was looking to have a meeting with you." Then I thought, he must have known that I'm a president of Indian Psychiatric Society, president of WASP, he must have thought of something like that. But he mentioned only one thing. I am told that you give free service to these poor people. And he mentioned nothing else. So ultimately what is counted is our work with these collaborative people. That I have felt very deeply, and I think we should all take a lesson from that. Thank you.
Thank you so much, sir. I'm just conscious of the time, so without taking any further questions, we have Professor Mohan Issac, and I have requested sir to give a kind of closing overview with his wisdom. I'd just like to say, so I'll give him the floor now, but I'd just like to say this has been such a tremendous session for me in person, sitting with 4 of my gurus in many ways, you know, in my teachers. And in this hall, it has been a humbling, inspiring experience. Dr. Mohan Issac, please.
Yeah, thank you very much. When I first got this invitation for the Social Psychiatry Conference, and when it was said that there is going to be the theme symposium, we are inviting you to speak at the theme symposium, and the theme is Social Determinants of Mental Health. Very honestly, my first thought was, of course, the organizers, Scientific Session Committee, as well as the ASP office bearers, have done the politically correct thing. Social determinants of mental health, it's a slogan, people are talking about it. Okay, we start the conference. Of course, in the morning, Debashish mentioned that this is not like the IPS conference, this is the IASP conference. IPS conference, big numbers, lot of lavish lunches and etc. Here, simple food, lot of academic activity, people don't walk out, etc. He has already mentioned that. But even then I thought, okay, this is just a, decorative kind of a theme for beginning the conference. But I agree with Dr. Basu that this has been a very enriching symposium. Because if there has been so much of questions, starting from the role of carers, what can we do about carers? Madam Indra Sharma said, our patient we can talk to, but the parents are so obese, we can't talk to them. I don't agree with her. We can certainly talk to them and they will perhaps take it from us than anybody else. In fact, there are carers organizations coming up. If you don't have the time to talk to them, refer them to a carers organization where they have the kind of which Dr. Murthy mentioned, Schizophrenia Awareness Association, etc. Care for the carers, etc. So starting from carers, the role of peers, Madam mentioned about what to do, role of social media, how is it that it is not a part of the social determinants? When all the people started writing about social determinants, it was poverty and all the things that we mentioned. Social media is a more recent thing, and if you're in the committee, it must form a major place in the RANZCP. So what I'm trying to say, point number 1 is, this has been a very rewarding and provocative symposium which made people to reflect on number of things. That is how the questions came. Usually again, I mean, I am a very active member, the president of the IPS is sitting here, it is nothing against her. But if in IPS meeting a session was going on, by the time it would be only the panelists and the front row who are past presidents, etc. Most others would have gone to the lunch because you have to have queue, there are much more exciting things there, etc. Here nobody has gone out. Sightseeing. Anyway, so it has been a very, so compliments for... President, they have all, they have also not gone. Anyway, this is in a very jovial way. I have out of the 70 odd IPS meetings, I have attended most of the IPS starting from 1974, except when I was physically sick, wherever in the, so I can speak with confidence about my observations. And I'm sure all people who attend IPS conference also agree with that. That's the point aside. So this has been a very provocative and thought-provoking symposium. It doesn't stop here. It's all, action. What Dr. Murthy ended by saying, this is not enough, we need to act. So that is the first point. Second point is, we need to, the point which Madam Savita mentioned, and our training, we need to radically think about our curriculum. And this is not occurring just here. Just yesterday, I was in a webinar with Subodh Dave, who is the Dean. He's finishing his 5-year term as the Dean of the Royal College of Psychiatrists. We borrow lots of things from Royal College of Psychiatrists. The initial DPM program, which was started in All India Institute of Mental Health in Bangalore, which is now the MANS, was the Maudsley 26-month DPM program. Mayor Gross came and started. So we borrow a lot from our British training. Now he was the Dean of the Royal College of Psychiatrists for the past 5 years. It's very likely that he will become the President of the Royal College of Psychiatrists, because he told me that he is contesting in February the nomination. Hence, he is already nominated by the RANZCP board. There will be others who will oppose, but it's quite likely he will be probably the second Indian origin President of the Royal College of Psychiatrists. He told me, what we are failing to do, we are training very good psychiatrists who know the best practices. What is a dose of clozapine, how to receive the patient and shake hand with them, all good practices. But we have failed in training them to empathize with our patient. It's a different kind of training. So he said, I'm now going to, if I become president, I'm going to focus on major curriculum changes. He was in Australia about 3 weeks back, talking to the president, vice president, and the curriculum revision committee of the RANZCP about training. I'm only responding to the point that we need to radically reflect on our training. Are we training? And the other problem within Indian training is that we are training our psychiatrists for practicing in Australia, in UK, in United States, etc. So curriculum revision. And in this respect, I would just in passing mention there is an excellent group called the Indian Teachers of Psychiatry. They have a website, lot of work, they publish lots of papers. Many of you have been participating in it. At least I know Snehil, who is sitting there, was a scholar of the ITOP. Please do go and contribute to that. We need to improve psychotherapy training, and Rakesh talked about social determinants. And incidentally, I'll just mention, recently I wrote an editorial about reviewing the role and status of social and behavior sciences in medical education. All over the world, we say it is important. Medical students have to be taught sociology, psychology, but like some of the graphs which Debashish showed, it is declining. There is a hidden curriculum. And that is one of the reasons why I was pleasantly surprised when the dean of the institute, who is a professor and head of the Department of Medicine, talked about the fact that medicines play only a small role by giving examples from his own life in the past 12 hours. Morning rounds and last night. 2 people, 30, 35-year-old died. With the advancement of medicine, we could not do anything about that. Part of the problem why social and behavioral sciences are not taken up is a hidden curriculum. Like Dr. Murthy mentioned, the barriers are ourselves. You know, we are so much into biomedical, what biology can do, what medicine can do. We have talked about that in Debash's presentation also, the taking over of social psychiatry. No land for us, he made a passionate plea. I think we have to, all the teachers here, have to make a real passionate effort to review our curriculum and be role models. There are no textbooks, there are no ways of teaching empathy. You are the example. You have to. So there is a need to, I'm highlighting the need to include social determinants of health and mental health into our training. Now, the other problem is that, you know, social media, all these are coming, peer group, and there is a role, there is a tendency all over the world to medicalize behavior problems. I'll give just one example. In Australia, which again is because of the peer pressure, is a new problem amongst children and young adults called gender dysphoria. A 10-year-old, 12-year-old tells his parents, oh, I'm a boy, but I don't like to be a boy. I feel like being a girl. Why? Because some other girls have talked about it in some social media. And then they go to a doctor. We want gender change thing. So there is a story, Neeraj will know, in South Australia, I think a psychiatrist said, no, this is a behavior problem, we need to correct it. And she refused to refer him to, and the parents said, no, my child is suicidal. And the psychiatrist was not dismissed, suspended from the thing, saying that you don't go with. So there is not only peer pressure, parental pressure, the need to confirm with the others, etc. So we are medicalizing newer and newer problems. Dr. Murthy showed all the calendar months, what we have been ourselves highlighting. So to conclude, I think it has been an